And I'm happy to welcome you to this session on administration and best practices related to documentation and privacy. As most of you know, Nikki Miller was scheduled to give this presentation, and we lost Nikki about 2 weeks ago. So we wanted to put together just a little piece of a memorial for Nikki, recognizing her, honoring and respecting her. We've actually kept her slides as intact as the presentation was scheduled to be given. And we have Peggy Gemperline, a dear friend of Nikki's and the Vice President for Residential Services for Pinnacle, who's going to come and give the slide presentation virtually. She's on the East Coast, so she's going to be controlling it there. And then I'll be here in the room with you so that we'll have that opportunity in terms of the back and forths. And yeah, so just to recognize and honor Nikki, if you can also go to the next slide. This is a picture that makes me smile, and you see Nikki. Every time I look at this picture, I just smile because you see Nikki, and then you also see Peggy in this picture as well. So you can see that these are real live people, kind of really committed to the experience, committed to doing the work to improve our services and to make things really great for everyone. And with that, let me see if we can get Peggy on the line and go ahead and switch to the next slide. Great. And Peggy, are you here?
I'm here.
Great. Take it away.
Hi, everybody. It's an honor for me to get to do this. I've presented with Nikki a couple of times, and so I understand her process, and I want you to understand that I do have Nikki's slides, but Nikki always creates a notes document for herself, and I don't have that. So I have taken her slides, which are very well annotated, and read up on everything that she has. But you know what you're missing out with Nikki is her passion. Nikki is somebody who has always been a fierce advocate for marginalized people, particularly women and people with substance use disorders. And it would only make sense that she would take the same approach with regard to federal privacy laws protecting people who are receiving treatment. And so she's probably the only person any of us would know that would put together a presentation about 42 CFR Part 2 that at the end of it, we will likely be ready to march on Washington. So you can go ahead and advance the slide. And this is the disclosure, maybe the next slide. It is National Recovery Month, so recovery is for everyone. Next slide. I think one more slide and we'll be there. There we go. So I didn't know this was what Nikki was working on when she called me, and she said, did you know that servicemen that were coming back from Vietnam had to be drug tested once they returned home? And so many of them had to, quote unquote, dry out before they got on the plane. Otherwise, they would be put on a drug farm when they returned home. And she was referring to information that during her research she found when she was looking at a document on the 1970 Controlled Substances Act. And so, basically what that did was further criminalize drug use and drug possession. There were already some laws on the books, but 1970s Controlled Substances Act by Richard Nixon further defined what the minimum jail sentences would be, minimum fines, so on and so forth. And so it was the start of the war on drugs. And so, as Nikki said here, in 1975, one war ends and another begins. And so 42 CFR Part 2, for those of us that are in the field, we receive this information every year. It is there to protect people who are seeking help for a criminalized behavioral health disorder. And there's documented racial bias on how this has been, how this has affected our population. Opioid addiction with effective but stigmatized treatment is particularly of concern. When this law was enacted, we had another opiate epidemic that didn't receive the national attention that the current one does. And that may be because it affected by far people of minority more than it affected people who are white. And so when OTPs first opened, police would raid the OTPs or go out in the parking lot, and it was literally like shooting fish in a barrel, as they say. They could find people who had warrants for low-level drug offenses, and this is part of why 42 CFR Part 2 was enacted. We'll go to the next slide, please. So there have been some changes at the federal level for this law. And so in 2011, with the Affordable Care Act, in a letter from SAMHSA and the plan, SAMHSA stated that we needed to modernize due to health information technology, EMR systems, prescription drug monitoring programs. And the key word there was integration. There was lots of talk about integrating behavioral health care and primary care, electronic medical records that had behavioral health functionality in a primary care health center. And so 42 CFR Part 2 made it inconvenient, so to speak, for information to be shared between two entities of the same organization that were providing two different types of care. In 2016, there were some public comment on proposed changes, and there were concerns expressed by many stakeholders, the AMA and others. The AMA stated specifically that knowledge of all medications is important, but negative effects are far more likely when a person who is in treatment, their health record becomes shared. And so in 2017, SAMHSA had a final rule, and it changed something with releases of information. Releases of information include general answers, who, what, why, how long. 2018, supplemental rule changes, releases of information applies to all payment and or healthcare operations. And, something interesting now is that healthcare operations now includes case management and care coordination, which we generally know as part of the provision of substance abuse treatment. In 2020, the interim final rule, OTPs may disclose to prescription drug monitoring programs in states where it's required, central registries with consent, and information that is communicated verbally doesn't fall under protection of Part 2. So the same information shared in different ways doesn't have the same protection. So information shared from a Part 2 covered program with a non-Part 2 covered program, if it's shared on the phone, then it doesn't become part of the medical record, and so it's not protected under Part 2. If it is faxed and it's in writing, then it becomes part of the medical record and is protected by Part 2. And so then we have the CARES Act with mandated changes. There's changes in law in response to the pandemic. And so you've got blanket release of information that covers all actors. So these are just some of the changes that some consider to have watered down the protections that are provided to people who are receiving substance abuse treatment under Part 2. And so if we go back, I know that it's in the slide somewhere, but I think it's important that we just recap what a Part 2 program is. So a Part 2 program is defined as a program that puts itself out there as providing substance use disorder treatment specifically. And so a doctor's office where the main thing that physician provides is primary care, but they may have a couple of patients that have opiate use disorder, and so they prescribe Suboxone to them. They have an X number. He's not necessarily considered a Part 2. His records are not protected under Part 2. But a substance use treatment program that receives federal funding, that's what is defined as a Part 2 entity. And so non-Part 2 entities oftentimes have to share information with Part 2 entity. And so the Part 2 entity, or the substance abuse treatment program that needs to share information with a primary care provider, we need to take a lot of care in how we're sharing that information, because stigma still exists with substance use disorders, particularly people who are in treatment for opioid use disorder in OTPs. And so we have to be very careful about how we communicate information and how we educate our patients about their rights under 42 CFR Part 2. And so if you go to the next slide, there's information here about the CARES Act and further changes with regard to 42 CFR. And so the law that is the basis for Part 2 is what changed. And so SAMHSA's rulemaking process responded to CARES changes, and substance use disorder confidentiality protections are more closely aligned with HIPAA, and that was the goal. General consent that allows for all future consents until revoked. Now think about that. So we know that when we share information, I know my email, for instance, has that paragraph about if this email contains information about a person who is in treatment for a substance use disorder, then it gives information about how that cannot be redisclosed. And so now it can be redisclosed in accordance with HIPAA rather than the uses that were in previous versions of this rule. And so it allows for future uses until revoked. But if that information has been shared again, how does the entity that it was shared with know that the release has been revoked? That's, those are just a few of the conflicts that arise with some of these newer changes. Access for all treatment, payment, and healthcare operations for HIPAA-covered entities and business associates are also covered under this new rule. So let's talk about where key advocacy groups stand. Go on to the next slide, please. So American Society of Addiction Medicine is for the changes. And so the changes, really what has happened is the changes have been made that will allow integration of healthcare records, that allow health systems that integrate behavioral health and primary care, that they can share an electronic medical record, and that there is an ease of coordinating care between all of those entities. And so the American Society of Addiction Medicine believes that all prescribers and dispensers should be required to enroll in to report the medications that they're dispensing or providing if they're controlled substances. And one of the things that came up in the document that I read about this is that, physicians generally believe that they should have access to a complete list of the patient's healthcare information, including all of their medications, in order to make good decisions about their healthcare. Because medications like methadone, buprenorphine can interact with other medications. And so they believe that these changes will help facilitate better health care, but they believe that only clinical people should be allowed access, and law enforcement with only a subpoena. Now, we all know, unfortunately, that that's not the case. So if you look at prescription drug monitoring programs, for instance, many of those are controlled by law enforcement. So there's really no way to prevent law enforcement from having access to information on prescription drug monitoring programs, for instance. The American Medical Association, for the same reasons, is pro changes, and they believe that HIPAA provides enough protection. But oftentimes it's been my experience that patients who are in treatment, some of the stigma that they experience are specifically from the medical community. And so, a patient is in one of my residential programs, goes to the emergency room. When the emergency room staff know that the patient is from a treatment center, they're often treated very differently than other patients receiving care. The Legal Action Center is pro-privacy and resources, and this is an advocacy center for these marginalized populations that are likely to be affected by, the consequences of sharing this health information. The Addiction Forum is adamantly opposed to changes, and so is Faces and Voices of Recovery. And I think that that's important because these two organizations are made up of the people that are directly affected by the sharing of information from the health records of people in treatment. The American Association for the Treatment of Opioid Dependence are pro-privacy and resources. So there's a lot of disagreement between the affected entities about whether or not this law provides enough protection, facilitates better health care, and achieves its objectives without further harming patients who have substance use disorders. But the universal agreement, and you can go on to the next slide, it's on us to provide information in plain language that includes the rights that about our patients' protected health information, a brief description of how to exercise those rights, and what and when disclosure to allow disclosure without written consent. And I would add to that, one of the problems with sharing information with non-Part 2 entities is that entities that are not protected under Part 2 are not required to be trained annually about 42 CFR Part 2. So other healthcare providers often don't understand that there is a federal law that protects the health information of people receiving substance use treatment. Law enforcement definitely does not understand, protects the information of a patient who is receiving substance use treatment. An example of that, one of my programs in Kentucky, we had two employees that were arrested because they refused to violate 42 CFR Part 2 by identifying a patient in our treatment paperwork. They didn't. And even though they tried to explain what we needed, why we couldn't provide that information, failure to provide that information. And we were in court for a year. It wasn't until Pinnacle had to actually bring a federal lawsuit against Greenup County, Kentucky, in order for the county to drop the charges against our employees. And so damage was done. There were, we had one of our employees was a man of color who had a custody issue that was happening. And, his mugshot was on the internet and was used in those custody hearings. So it's, we have to understand that this is real, that there are consequences both for those of us that work in this field with people whose information we need to protect, and for our patients that are trying to get help, and that the stigma has not gone anywhere. So let's have a poll and ask yourself, how confident are you in yours or your staff's ability to explain what patients consent to when they sign a release of information? You can go on to the next slide.
Very confident? A little
Okay,
confident?
so yeah, high level of confidence, fairly
No
confident.
confidence? In the room, we're sort of in the middle. Like some people have no confidence, some medium, and some a lot.
Okay, so for those of you who have a lot of confidence, can you share something about how you were able to achieve this?
Volunteer in the room? Walking towards somebody. Look at them looking away. Can you share how you know? Somebody else want to let her off the hook?
Yeah. Sharing with patients the information on the informed consent is to talk to them about like what we're going to share, ask them what they would like us to share and not to share, and have a conversation with them and let them choose what we are going to share with outside entities.
Excellent, thank you.
And having transparent conversations with them about what we can and can't, what they are signing, and if they're signing that it's okay for us to release the information, having really transparent conversations about what that exactly means and what the consequences, for lack of a better word, mean from that. Yeah, and
Yep.
what team members as well.
Back to you, Peggy.
Okay, and so for those of you that are not as confident, what would it take for you to boost your confidence levels?
Well, I do have really transparent conversations. I guide them on how they want to use the consent, but I have no faith in our Epic. Their labs are not protected. Their meds are not protected. If they're underage, their parents are still going to get an alert when they have an appointment with me. There's not a workaround. I work with our pediatrics. They have the same problem. We don't have shadow charts, which we should have. So I have a big problem. And I go over what I will not give to POs or law enforcement unless there's a subpoena. I've never been subpoenaed, but I definitely get hit up all the time by POs and the deputies. And my staff is really good, but there's only so much we can do in our clinic. It's a bigger problem when it goes outside our little clinic. It goes to the bigger picture. I'm not as confident. So I cannot say to them, it won't be shared, which is pretty hard.
Thank you. I really related to that because, the thing is, I try to stay up to date on the changes that are occurring with regard to patient privacy in our field. And, what's happening is that, we are still required to get a signed release of information from the patient. However, that release of information becomes less and less protected when we share that information with entities that are not covered by Part 2. And so, patients, I don't know that they know, and I need to look at our releases again to see that if our patients know that if we share something verbally, then it doesn't become protected under Part 2. So it can be shared in accordance with HIPAA, which is not as stringent and isn't protected from law enforcement, for instance. Okay. So if I share with their OBGYN information about their substance use disorder treatment in an OTP, and the court that is anti-MAT subpoenas the OBGYN, they don't have to have a court order, because we actually can't share this information with just a subpoena. We have to have a court order that requires a separate hearing, and therefore it needs to be a serious crime. It can't be a possession charge, you don't get a court order with a hearing in order to get information for a drug possession charge, okay, or probation violation for a low-level felony or high-level misdemeanor. And so, but it's not protected at the OBGYN's office. If I called the OBGYN and gave them information about the patient's treatment at the methadone clinic, and that is written into their health record at the physician's office, it's no longer protected by Part 2, and therefore it can be subpoenaed for any reason. So it's, those are things that the field is not clear about, and I tell you, to be very honest, because, many of our staff are hired, they don't have a background in SUD treatment. And so we hire nurses that haven't worked in this field. They're seeing 42 CFR for the first time. They're only half listening because they've been hearing for years about patient privacy under HIPAA. And so there are specific things that they don't know about in relation to 42 CFR and the health records of people who are receiving treatment at our facilities. So, when the sheriff's department comes to one of our facilities, how confident am I that the nurse that's working or the, front desk person is clear on exactly what they can and can't say to the police officer? If we receive a subpoena, will our medical records person know what they can and cannot provide under this new law and who they can provide it to? Now, I know that Pinnacle has a pretty good compliance department, and all of those things go through them. However, once that information leaves our building, I'm not real confident that it's going to be protected. Go ahead to the next slide, please. So I talked a little bit about this. So Part 2 qualifications we talked about. And for us, those of us that are Part 2 entities, the release of information is now a blanket consent for all payment and care operations. And care coordination and case management is considered healthcare operations, which is strange to me because that's, those are services that we provide in our programs. A release of information is not required for a medical emergency, which includes public health emergencies. I can understand that. OTPs may report data to prescription drug monitoring programs with consent if state law mandates. However, if state law mandates, and I don't believe it does in California, does it? Can somebody answer?
Someone saying, no, it does not require it.
Okay, good. But for those that it does require it, if we get a release of information, I wonder if the release of information specifically says that, what kind of access law enforcement has to that monitoring program. And then undercovered agents are allowed in Part 2 programs by court order, and there is less control over this. In the past, if a court thought that there was criminal activity at a treatment program, undercover agents could go into the program with a court order for 6 months. And then if the investigation needed longer, then they would have to petition the court and give them reason why they needed more time. And now there's less control over that. It's a blanket 12 months. So, those things don't happen very often, but they do happen. So non-Part 2 entities, hospital, medical, if there's no dedicated substance use disorder staff or unit, then they're not covered under Part 2. Substance use disorder services, programs that only accept private pay or private insurance aren't covered under Part 2. OBGYN for pregnant and postpartum women, whether or not buprenorphine is prescribed, if it's not a substance use disorder program, if it's provided as a physician's office, and then, for instance, information or verification of counseling is provided by an external entity, then they're partnering with a Part 2 program, maybe, but they're not a Part 2 program. And then Part 2 doesn't cover most overdose emergency crisis care, and then criminal justice, even when contracting Part 2 entities. Next slide, please. So some of the benefits of the new final rule. Okay, informed consent with a written release of information is still required, regardless of who we're sharing the information with. All disclosures, all consents can be revoked in writing. But what impact does that have on redisclosures? If it's been disclosed, if the information has been disclosed, regardless of whether, who it's disclosed to, how do those entities get information about the revocation? And do they? A court order is still required to use this information in civil, criminal, legislative, or administrative proceedings. It still protects from discrimination due to intentional or inadvertent disclosure, or at least it's designed to. And then patients have the right to limit how the information is used. So, an example is that a release of information that is provided to a healthcare institution, under the current rule, it can be a blanket release of information to that hospital or that healthcare system, but the patient still reserves the right to limit and name the specific person to whom information can be shared. So they have the option of that, but it's not required. Patients also need to understand that information that is given verbally is not then protected if it's shared with a non-Part 2 entity. And so they need to have the option of whether or not to allow verbal disclosures, discussion over the phone with their other providers, for instance. Next slide. And so this is just an example of how confusing this can become. particularly with the bottom picture. I know I don't know if you guys can read this. I really had to make this bigger. But in the first picture, you've got patient Joe, who goes to Memorial Addiction Treatment Center there in the middle, and he provides a compliant consent to discuss information about his substance use disorder treatment with Dr. Jones. And it's an independent conversation about Joe's substance use treatment. Now, if that information is provided in writing, it becomes part of medical record. If it is not provided in writing, it does not. It may become part of the medical record, but it's not protected under Part 2 against redisclosure. It can get very complicated, as illustrated in the second diagram, where you've got a community mental health center, and there's a health information system and a health system that is allowed to share information. And so with this type of health system, an HIE, this information could go to, for instance, every local provider in a geographic area. So it can get rather complicated protecting the information. Next slide, please. And this is very Nikki Miller. Big data and ending discrimination. What could possibly go wrong? Next slide. The key difference here is criminalization. Addiction is a behavioral health disorder that is criminalized, and there is demonstrated, it affects certain minority populations more than it protects, or it affects minority populations more than it affects white populations. And so places like Narcotics Anonymous, Narcotics Anonymous, when it was first formed in the 50s, late 50s, it was actually against the law for known drug addicts to gather in a place. And so, it was always a risk for groups of individuals trying to recover from addiction to gather together in the same place. And so, part of what they read at NA meetings is that we're not connected with any political, religious, or law enforcement groups, and we are under no surveillance at any time. And that was, so that people would feel safe under circumstances that are very real circumstances with criminalized illnesses. And so I have a quote here that Nikki made reference to. And this is the war on drugs levied harsher penalties on people of color. And so prison sentences for use of crack cocaine prevalent in Black neighborhoods were heavier than for use of powder cocaine favored by whites. The disparity had its roots in the drug policies of the Nixon administration. As Nixon's domestic policy advisor, John Ehrlichman, admitted to an author in the 1990s, the Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black. But by getting the public to associate the hippies with marijuana and the Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. And this is, a policy advisor in the Nixon White House that played a part in the 1970 legislation. Next slide, please. This is one slide that I couldn't find all of the specific information. I think I get the gist of it. Criminalization is not an equal opportunity destroyer. So, we know that in Black and brown populations, that they are more heavily penalized by the legal system for drug use, drug possession. There's a shortened life expectancy. 80% of convicted, 80% convicted of heroin trafficking are Black or Latino, and the likelihood of arrest is 13-1, which is very different than the white population that are affected by drug use. And in my own community, I was looking through, there's a Facebook page that shows the indictments in the area by date. And so every week there's a whole list of people and their pictures and what charges they were indicted on. And I just looked through this as I was working on this, and I saw that it was very predictable when when the person was white, they generally the same situations were generally charged with misdemeanors or low-level felonies. But almost every single person who was not white that was on that group, they were criminal. They were prosecuted or charged with trafficking and level 1 felonies. Next slide, please. Discrimination in healthcare settings. So the Americans with Disabilities Act doesn't cover people who are currently illegally using drugs. So therefore, people who are addicted, who go to the emergency room and are in pain, or have an accident, or and they test positive for an illegal substance, they can be discriminated against, at least under the ADA. I wonder how many of you have had your patients discriminated against in the ER? I can't see you, but I would imagine there are some hands up.
I'd say more than half of the room is raising their hands.
Absolutely, absolutely. I've heard horror stories from, my patients about what happens to them in the emergency room. So next slide. So peer support specialists. Peer support specialists are also covered under Part 2. So there are limits to what a peer support specialist can disclose. They fall under Part 2, and so they should have receive information about patient privacy. Most of the time in the states, at least that I'm familiar with, that my programs are in, it's part of the certification process that peer support specialists are educated about 42 CFR. Next slide. So if we're working in custody settings with the justice system, let's say that we're providing methadone for the county jail or a prison. I think it's, we know that we disclose the least amount of confidential information necessary. Next slide. This is more about Cures Information Practices Act and prescription drug monitoring. And so, physicians and providers are required to consult prescription drug monitoring before prescribing Schedule 2 through 5 controlled drugs, and then review at least every 6 months. But OTPs and NTPs at this time are not required to report administered medications in most states. Next slide. patient protections, recourse, and remedies. The Confidentiality of Medical Information Act in California allows any individual to bring an action against any person or entity that has negligently released confidential information or records for either or both nominal damages of $1,000 and the amount of actual damages, if any, sustained by the patient. It shall not be necessary to prove that the plaintiff suffered or was threatened with actual damages to recover nominal damages. And so here's information also about how to submit a complaint. Next slide. So what are your concerns about potential impacts on the people you serve based on your experience? So tell me what some of the concerns that you have are.
Who wants to share?
Thank you. Some of the concerns I have are, I feel like we've come so far in the realm of treating substance use disorders as a disease, utilizing the disease model concept. And I continue to bump up against Part 2, CFR Part 2, in the way of that I feel like we're almost continuing to perpetuate stigma by placing substance use disorder records and their information in a box instead of just including it in HIPAA. So that's the challenge for me, because I know for any clinicians or all staff for that matter that are onboarded into our organization is we're really clear that this is a no-go, stop. If you disclose records outside, we protect our patients, we do the best we can, but we also explain to the patients that we need to collaborate with primary care. We need to collaborate with the other resources to be able to get you to where you need to be. And we do that with respect for your records. And we're here to protect you. So I think for me, it's almost a double-edged sword at this point that we're continuing to perpetuate this stigma while we're also trying to put it in a medical realm. I don't know. Those are my concerns.
Okay, fair enough. Yeah. And I think that I think that in some ways you're right. I agree with you that anybody that's providing care to our patients needs information about the full picture of their health history. and I think that would be, ideal if, there wasn't stigma already for people who have substance use disorders. I don't know what the experience, if the experience is different on the West Coast. I know that, there are certain areas in Ohio, for instance, that if a judge finds out that you're a methadone patient, that they will automatically, it'll affect how well you do in a court case with that judge. Many sheriff's departments that control jails in Ohio, for instance, they will not allow people to take their medication for opioid use disorder while they're incarcerated. So, there's an argument to be made on both sides. Another issue, I've had a sheriff call me on my personal cell phone and threaten that he will bring, the SWAT team into my program if I don't identify a patient for him. Those are the things that make me pause when considering changing the rules about sharing health records. The more that we water it down, the more that those stigmas can negatively impact the people that are in our care. Anybody else have a comment?
I was gonna say something, but now hearing you say that made me change my thought. out the, I mean, working in the field and trying to navigate the system or coordinate care for patients is just like, is such a barrier sometimes to get things done, or you got to fill out 2 or 3 or 4 forms, 2 for each provider, or, it's just a hassle. But hearing that in another state, I mean, we can't just get rid of people too, but there's got to be a way to educate the courts and all that stuff for them to not be producing or keeping that stigma across, the whole United States. But it really just hinders care and slows things down. And I mean, I wish we could get rid of it, but hearing what you just said right now, I haven't had that experience working where the cops come tell me that. Or they're using some kind of negative benefit. I mean, this person's on methadone at the court, or we're going to send some for a little longer, or we're going to do something like that. So I could see the benefits of it for that. But for somebody that's coming in and trying to help our patients, sometimes it puts up a lot of different walls and barriers to get services that they need. And it just slows down the process.
I agree. The administrative burden that it puts on us is big. I mean, it's significant. And that's part of the reason why, there's so much conversation about what we should do with this rule. With the pandemic, we had patients that were impacted by COVID-19 and hospitalized, and we needed to have a way to communicate their care with their current, care provider in the hospital. So there definitely is an argument to be made on both sides of this. I agree. And I also think that, one of the things that you said is key: education. I think that, law enforcement groups, if we were able to provide more education, it might reduce the stigma to some extent.
Even if we educate them, if they don't follow suit, eventually we should criminalize them. Let them feel it on their side,
And that would make Nikki Miller very happy. Yeah. I totally agree. It's the stigma that should be criminalized. Okay. And I think that's about it. There are some discussion questions.
Peggy, we do have a couple of other comments in the room.
Yeah,
I'm sorry
go
about
ahead.
that.
That's
Passing
okay.
over the microphone.
Thank you. So I work at an FQHC, and we have we have a primary care operation. We also have our sub-treatment program. We have behavioral health, and then we have integrated behavioral health. I mean, it's pretty easy to silo the behavioral health notes and kind of put those in a box, if you will. But we have this integrated program where they're, embedded within primary care, and there's quite a bit of interaction. So there's just, I guess my concern is just remaining in compliance and just keeping up to date on what's what. But even when we talk about, let's just say you're doing Suboxone treatment. I mean, we have how it works for us. If we have, we have our program that's it's a standalone program. It's not embedded in primary care, but for our patients who are, very stable, we'll move them back to an X-waivered primary care provider. But that's, it's kind of falling into a different bucket of medical records. And typically, like if there's a records request, the medical records department will come to me and make sure, they'll clear release of behavioral health records. But there's always gray areas. And I don't know, just, it's one of those things where, compliance is an issue, but it just kind of gets put on the back burner. And it's not like we have, a compliance department staying on top of all this and up to date with all this. So I think really coming into this talk, it just, I guess, brings up that need for us to, I guess, it's almost like we need a dedicated person in our department just to stay up to date on on these changes to keep us informed to make sure we're in compliance. But I appreciate the information and I appreciate how you've laid it out. It's, it gets complex, but this made a lot of sense to me. And also, I think I hear a Southern accent, so that's awesome. I'm from Tennessee, so.
I'm from Kentucky, so.
Okay, I thought, yeah, it had to be Tennessee or Kentucky. I was born in Louisville. So anyway, yeah, welcome to California. So.
Awesome, thank you. It does get complicated, and there are medical records that are working hard on how to isolate and segregate the SUD provider information from the primary care. So, but yeah, you're absolutely right. I mean, a company the size of Pinnacle, we have an entire department of, really attorneys and nurses and clinicians that oversee, our compliance with this rule. So it is complicated. And I can appreciate that.
Yeah. And Peggy, we're about at time. I don't know if you have closing slides or a closing comment. And I know we need to get to the final code for everybody as well.
You go ahead. I think we shared most of it.